Totally.
Great. Thank you so much, everyone. So I guess first I'd just like to acknowledge all my co-authors. It's a sort of a broad project based on work done by the community and a variety of different research organizations, and particularly Alison Marshall, who's the PhD student who's been working on this. So if we speak about people who inject drugs in general, we've seen it's a highly marginalized population with a high prevalence of chronic hepatitis C, but there's other causes of chronic liver disease, including alcoholic-related liver disease, fatty liver disease, and chronic hepatitis B. Now, if we look at barriers to HCV care among people who inject drugs, there's sort of a number of different barriers at the level of the patient, the provider, and the healthcare system. So when you ask people who inject drugs, why have you not sought treatment for hepatitis C, one of the things that generally comes out is I feel fine, I feel asymptomatic, or I don't know a lot about hepatitis C, and I don't know about treatment. There's also obviously issues of stigma and discrimination and social situations, which also preclude, thinking about initiating therapy. We also have provider-related barriers. Some practitioners are not aware of that there's even a cure for hep C in terms of general practitioners, and there's concerns around reinfection and adherence to therapy among people who inject drugs. And then at the system, there's obviously long wait lists and prohibitive perspectives in terms of access to care. So in terms of thinking about how we might be able to enhance HCV assessment, the availability of FibroScan provides a really unique opportunity. It's a non-invasive procedure with excellent diagnostic accuracy, at least in terms of distinguishing people with very severe advanced disease with cirrhosis from those with mild liver disease. So one thing that has been proposed and been done in other settings is, well, could you integrate mobile FibroScan as a targeted health intervention, and this could provide an opportunity to enhance screening and assessment for hepatitis C, particularly in the drug and alcohol setting. So LiveRLife is a healthy liver campaign that hopefully would provide a framework for evaluating enhanced disease assessment in this setting. So as I mentioned, it's sort of a three-phase project. The beginning of the campaign was around message development. So we did targeted focus groups with community peers. The community was heavily involved in the initial phases of the campaign. And really, we did qualitative interviews to look at barriers to knowledge, attitudes, and beliefs around both liver disease and also hepatitis C. And it was interesting how hepatitis C was very much a focus, but there's very little focus on liver disease. So hepatitis C was prominent. And so then we developed some messaging. I'll show you some of the materials, and we focus tested the messaging and the resources with community peers. The other thing is we worked with a social marketing research group who actually helped inform the campaign. So it was really to try and understand, what could we do in terms of a social marketing campaign to enhance uptake of screening. And one of the things that came out is that in terms of an outcome, we had to sort of target one achievable behavior, and this was around getting a liver scan. They'd heard the messages about getting tested for hepatitis C, and so that was our sort of one achievable behavior. So in terms of the campaign messaging, so there was sort of a call to action, and that was sort of get a liver scan. There was posters in the clinic room, so it was get a liver scan, FibroScan. It's quick, free, quick, and painless. So those were the things they wanted to know from their perspective. What was it going to cost them to be involved? And the fact is that the cost wasn't very much, and the benefit would be that you would know what your liver status is. So the posters were up in clinic waiting rooms, and you could sort of have a site contact who is generally a nurse at the clinic, and you could speak with someone to sign up for the campaign days. So essentially what happened is the campaign days rolled one day a week over 4 weeks at each one of the clinics, and these are all the different mechanisms that they could sort of engage with to be involved in the campaign on the days. So we had a broad range of different resources that we developed. So we have a printed resource. It's called The Tips and Truths About Your Liver, providing education about liver disease, sort of dismaying myths about the factors that influence disease progression, a little bit about treatment. There was a poster campaign that ran within the clinics. And then a short film that was sort of running in the waiting room on the day around sort of liver disease. There's a FibroScan report that we created, and I'll explain how that fits in, but you can see there from sort of mild to cirrhotic liver, and we generated these that the practitioners can use, and there's also a study website. And I should say that all the materials that were developed, we've been partnering with Hepatitis New South Wales, so these are actually all available online now, and we've sort of made them available to practitioners in Australia. So in terms of phase 3, so then what we did was we wanted to evaluate the impact of this Healthy Liver campaign on liver disease knowledge, assessment, and treatment among people attending drug and alcohol services in New South Wales, Australia. So the inclusion was that you had to be greater than 18 years of age, had a history of injecting, and then pregnant women and those who had had a FibroScan or biopsy in the past 2 years were excluded because they might have had pre-existing knowledge around liver disease, so we didn't want to bias that. And you couldn't have had previously received or currently received HCV treatment. And the recruitment was through a network of 4 opiate substitution treatment and drug and alcohol clinics in New South Wales, and also the Sydney Medically Supervised Injecting Centre. So on the campaign days, what would sort of happen, we'd have sort of food. I was actually the barista, so making coffee, engaging with clients, and in the clinic waiting room. And so they would do informed consent and study enrollment. They'd sort of complete a survey on tablet for a variety of different demographics. Then they would go in and see a clinician. So Greg Dorr was actually the specialist in doing FibroScans. He would try as hard as possible not to tell them their score, and he'd write in their score, and then they'd go in, and then they'd see a nurse. So the engagement with the research team is then with the nurse then at that clinic, and that engaged them then into the follow-up of care in that clinic. We did a dry blood spot test so we could do antibody testing and RNA testing, and then there was a post-FibroScan assessment survey. So here's a couple pictures. We had a peer worker, which was incredibly important, or a community person, and so we attended each campaign day for 1 day a week over the 4 weeks, and then we had support staff from within the clinic who also worked with us so that these patients had some sort of maintained follow-up in care and linkage to care. It was really amazing seeing sort of the buy-in in terms of the clients and their keenness to participate, and it was interesting seeing the FibroScan and them trading score, discussing, and it was very engaging. So just in terms of the characteristics, so it's about 250 individuals, 253 that were enrolled, about 3/4 self-reported having hepatitis C, average age of 43, about 2/3 male, 21% Aboriginal ethnicity. You can see very low proportions that had been engaged in full or part-time employment, high proportion in rented housing, and a large proportion going through prison. You can see about 2/3 had ever been in, and then about 1/3 in the last 12 months, just reiterating that point about how important that population is. So in terms of willingness, so quite high acceptability, 88% were definitely willing to receive a FibroScan. And in terms of the preference, so 65% prior to getting the FibroScan would prefer FibroScan as a way, 16% through phlebotomy, 19% through liver biopsy, and then afterwards, this increased to 89% in terms of acceptability. So clearly an acceptable mechanism. If we look at disease staging at baseline, remember, not all these people were hepatitis C infected, but you can see that almost 20% had moderate to advanced disease, so F3, F4. But the majority, actually, about 68%, were at F0, F1. But really showing that, given we've discussed about the costs of the new drugs and the potential that there's going to be restrictions based on disease staging, this could represent an opportunity to triage patients who are at more advanced disease in terms of more immediate therapy. I just wanted to briefly touch on the clinical follow-up because I think it's quite nice in terms of, so these are the 4 clinics, and it was a variety of different sites, and I just wanted to sort of demonstrate, if you look at the follow-up, so the people that came back to see a nurse following the FibroScan assessment, it ranged between 33% to 70%. Now, the Supervised Medically Injecting Center, that was actually a different site, and they had to be referred off-site to another clinic. So in the other clinics where you were still engaged in care, it was about 50 to 70% of people came back for another visit, which is pretty impressive in this marginalized population. So look, in terms of, I guess, the implications of this, I think this is a really unique opportunity and tool for improving assessment and treatment of liver disease, and really try to improve education and engagement with people who inject drugs in the drug and alcohol setting, and this whole, provide an opportunity to get a liver scan, and we could potentially enhance and expand HCV care. So without that, I'd just like to acknowledge a broad number of individuals. I think I'd particularly like to thank Merck, because they've provided the funding for this project, and it's amazing what you're able to do when you're able to, when a project's well funded and you're able to do some of the formatory research to look at this. So yeah, it's really great, and a broad number of people at Kirby and other community-based organizations who are involved. So I'll take any questions. Thank you.
Thanks, Jason. It's a great talk. We'd be very interested in doing something like this in Scotland. And I'm just interested, you gave us some follow-up rates. Did those relate to disease stage? Did you find the cirrhotics were more likely to come back than the mild cases? It's
funny, I took that slide out because of time. I was already going really fast. He can get it up? The point is that the people with more advanced disease were more likely to come back for follow-up. So the people with F3, F4, I think the follow-up, there you go, 84% of those with F3, F4 came back as compared to 66%. But it was still high, and this is just in the clinics that we've looked at this yet. So yeah, it's great that those with more advanced disease are appropriately getting referred on because of advanced liver disease complications.
Great.
Nice work, Jason. This looks a lot like our community pop-up clinics in Vancouver. So I'd encourage everyone to come and see our poster and compare and contrast and see what can be done. A logistic question. Did you have them fasting before you did the FibroScan? Because as you know, food makes the kilopascals go up.
Sure, yeah, no, we didn't, Brian. Yeah.
Okay, yeah. So just to be careful in interpreting the F3s and F4s in that context.
Yeah, sure.
Thank you, Jason. Excellent. Just in a sidebar, I'd like to recognize that we're on Nakota traditional territory, the Stoney Nation. But are there any FibroScans available on Craigslist? Until in the northern regions, we're Aboriginal care, and we don't even know what the surveillance is up there for hepatitis C. I think that the fibro test is another element, and because when you're diagnosed with hepatitis C, it's 30% of the medical costs are getting to a community.
Sure. No, I can appreciate it. The one thing I'll say is, well, I can appreciate you have FibroTest and FIB4 and all these other things. Something about the FibroScan in terms of the immediacy of that result and the interaction with the provider at that time and providing that counseling, it's so powerful, and it's just different from having a result on a blood test. And so I just think that FibroScan's a bit unique, and I think that we should be exploring ways to get mobile FibroScans into remote communities, going up, doing a healthy liver blitz of a couple of weeks, and you just go in a couple of days and just blitz and get assess disease burden. I think that would be really useful for triaging people. But I know that we're short for time probably, so we'll probably end there. Thank you very much.
I think it's important because we can have reconciliation after reconciliation, and unless there is a meaningful movement ahead on the harms of the past, and this is the perfect opportunity. My organization has been going up to the north, doing workshops and raising awareness, and this is one of the concerns of the Action Hepatitis Committee as well. So, it has to be meaningful, and it's cost saving, because getting people up there or getting people down here for diagnosis is a lot more expensive than getting a vial of blood for the fibro test, I think.
No,
Thank you.
Totally understand. Thank you very much.